Good afternoon, everyone, and welcome to today's PHO webinar presentation on lessons learned from the collection of sociodemographic data during the COVID-19 pandemic. My name is Dr. Reid Morrison. I am a public health physician at Public Health Ontario, and I have the pleasure of moderating today's session. Before we begin, I will mention a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have any questions during the session. A discussion and question period will follow the presentation. It is now my pleasure to introduce the speakers for today's presentation, Manali Varia and Aideen Reynolds. Manali Varia is the Director, Public Health Intelligence at Peel Public Health, where her portfolio includes the work under the OPHS foundational standards, public health surveillance, population health assessment, evaluation, and emergency management. Manali is an alumna of the Canadian Field Epidemiology Program and holds a certification in infection control. She also completed a 2-year executive training and research application, extra, fellowship program, with a focus and interest for developing public health capacity to use health data for decision-making. Aideen Reynolds is a knowledge exchange specialist at Ottawa Public Health and has 20 years experience contributing to health equity in academic, community-based, and public health settings. Her current work focuses on expanding the collection and use of sociodemographic data for service quality improvement and program decision-making, and influencing standard sociodemographic data collection among local, regional, and provincial health system partners. I'll now pass the mic to Manali and look forward to the presentation.
Thank you so much for the introduction, and hello, everyone. During the pandemic, Ontario Public Health units expanded the collection of sociodemographic data during the COVID-19 case management and at COVID-19 vaccination clinics. Today, we look forward to sharing the results of a PHO-funded, locally driven collaborative project on the lessons learned from the collection of sociodemographic data. For our agenda today, I'll have a few opening slides and we will have 40 minutes for our presentation on our LDCP project, followed by time for Q&A. We invite you to enter questions in the chat as you think of them, and they will be collated and presented during the Q&A portion of our webinar. Okay, so our project is a partnership with Lead Health Units, Peel in Ottawa, as well as Unity Health Upstream Lab. Aideen and I will be presenting today and will be joined during the Q&A portion by Dr. Andrew Pinto. So we're happy to be with you today representing a larger team of individuals from our 3 organizations who facilitated the synthesis of this work. I'd also like to acknowledge that the land on where I'm presenting today, in which the region of Peel operates, is part of the treaty lands and territory of the Mississaugas of the Credit. For thousands of years, Indigenous peoples inhabited and cared for this land and continue to do so today. In particular, we acknowledge the territory of the Anishinaabe, Huron-Wendat, Haudenosaunee, and Ojibwe Chippewa peoples, the land that is home to the Métis, and most recently, the territory of the Mississaugas of the Credit First Nation, who are direct descendants of the Mississaugas of the Credit. I'm grateful to have the opportunity to work on this land, and by doing so, give respect to our first inhabitants. Our webinar today speaks to the responsibility that we all have in understanding our community, and to do this, we recognize the necessity for meaningful dialogue with Indigenous communities and with other communities who have settled here. And we have no disclosures for this presentation. So by the end of this presentation, you will understand the enablers and barriers to sociodemographic data collection for public health units during the COVID-19 pandemic. We also hope that you will be able to consider the pandemic lessons learned in your own context in order to support ongoing sociodemographic data collection and reporting. We started our presentation back in 2020 as the COVID-19 pandemic took shape, we began to learn about factors associated with an increased risk of exposure and infection. As in other areas around the world, in several regions of Ontario, people from racialized communities were overrepresented among those diagnosed with COVID. We knew that this was very much connected to the social determinants of health and systemic inequities. In June 2020, we saw regulatory changes under Ontario's Health Protection and Promotion Act, which mandated the collection and reporting of specified sociodemographic data for those testing positive for COVID-19. These changes coincided with the launch of the provincial CCM database for COVID-19 case and contact management. Later that year, in December 2020, the first COVID-19 vaccinations began. There were no parallel regulatory changes that were enacted for data collection for people who received vaccines. However, by March 2021, sociodemographic data fields were added to COVAX, the vaccination database, to provide an option to collect this information. But collection was not mandated by the province, and there were restrictions on reporting of data collected. Nonetheless, data were used in cases to show disparities, mobilize communities, and tailor interventions. When the PHO call for a locally driven collaborative project came to health units in the summer of 2022, Peel, Ottawa, and Unity Health submitted a proposal to understand the health unit experience with SDD collection and was approved in the fall and received RAB approval. The project work has taken place through 2023, and we're on the knowledge translation phase of our work. So I'll speak a little bit more about the methods in an upcoming slide, but I would like to mention the critical role to date of our knowledge user groups from pre-implementation to the discussion of results. Our knowledge users include other health units and health system partners, as well as community organizations in Ottawa and Peel, most of whom have been part of the high priority community strategy work. The research question for our work was, what PHU-led practices enabled higher levels of data completeness during the collection of sociodemographic data for COVID-19 case management and vaccine administration? Our objective was to identify a set of recommendations for SDD collection based on identified enablers and barriers that health units would be able to reference as they scale sociodemographic data collection beyond COVID-19 activities. For the purpose of this study, sociodemographic data collection was only fields captured in the provincial databases, CCM and COVAX. And so these fields included language, racial identity, household income, and household size. COVAX also included an ethnic origin identity field. And so our study results reflect health unit experiences collecting these 5 to 6 fields. We do know that from the perspective of our knowledge users, that this is not the full suite of sociodemographic data, as some key information is missing that would allow for more fulsome understanding of the determinants of health and inequities. In terms of our methods, recruitment of Ontario health units occurred through communication by existing listservs for medical officers of health and public health epidemiologists. The project was conducted in 2 distinct phases. So during the first phase, a survey consisting of both multiple choice and open-ended questions was administered to understand what did public health units do in terms of collecting sociodemographic data. In a second phase, we also explored PHU experiences with data collection using focus groups and interviews. And so together, this gave the research team an idea of enablers, barriers to data collection, and barriers to analyzing and using sociodemographic data. The survey data were analyzed as response frequencies, and for the focus groups and interviews, the team applied qualitative methods to transcripts to identify and confirm themes. As part of the recruitment, we had representation from different health unit roles, from frontline to senior management. I'll now pass it over to Aideen to share our results.
Thank you, Manali. Aideen Reynolds, Ottawa Public Health. And before I start, I just would like to acknowledge that I'm joining today from unceded Algonquin Anishinaabe territory. We extend respect and gratitude to First Nations, Inuit, and Métis people, their ancestors and elders for their valuable past or present contributions to this land. Ottawa Public Health works in partnership with the local community to promote social justice and to advance Indigenous rights and well-being here in Ottawa. So from the survey, what we wanted to know was what public health units did. What happened with STD collection, both with case management and in the vaccination clinics. So from the slide here, you'll see that all 34 Ontario Public Health units completed the survey. For case management, the column on the left, you'll see that 31 or nearly all public health units reported collecting. 24 began only after the sociodemographic fields were added to CCM and collection was mandated by the province. 5 reported that they had started collecting prior to the mandate, so they had developed their own local mechanism to do this, and 3 health units did not collect at all. As for who collected in case management, by and large, it was case managers, whether that was public health nurses or others who were helping with follow-up, such as provincial workforce staff. In terms of when, most guided their staff to collect during the first client interaction. However, many also indicated some flexibility to complete when appropriate for the client. In terms of monitoring, 8 public health units reported watching STD completion rates or monitoring data for completion, and 10 health units, or 1/3, reported sharing the findings. And you'll see that overall reported completion rates were very low, with the largest group reporting 26 to 50% completion. For vaccination, or the right-hand column there, 18 out of 34 health units reported collecting STD. Most began collecting after fields were added to COVAX. 2 began collecting before the fields were adding to COVAX, again using a locally created system to do this. And 16 did not collect at all. And if we compare this to the only 3 that did not collect with case management, we see a much less overall engagement in STD collection for vaccination. As for who collected, primarily it was non-immunizers, so data clerks or volunteers who were helping in the vaccination clinics. And when, more than half reported collecting prior to vaccination, so as part of registration or reception, whereas some reported also collecting with nurse assessment or in the post-vaccination waiting period. 8 health units reported monitoring data completion in COVAX. Only 2 reported sharing findings, and the overall completion rate for STD and COVAX were very low. You see there between 0 and 25%. There was one open-ended question at the end of the survey that asked health units to share anything they'd like us to know about their experience collecting STD during COVID-19. And responses to this question were very helpful to frame the question guide for the focus groups and interviews. Through those focus groups and interviews, participants identified several factors that impacted their ability to collect and analyze and use sociodemographic data. Themes were classified into 3 groups: enablers of collection, barriers to collection, and challenges with STD analysis and use. Starting with enablers, there were 4 enabling themes. The first was provincial direction. So Manali spoke about this, that the Ministry of Health implemented key actions to facilitate STD collection, namely the establishing of dedicated data systems with STD fields incorporated, and the legislative amendments to allow for collection were very helpful. The introduction of a provincial mandate, particularly in the case of COVID-19 case management, was helpful. to have these guidelines and training inspired health units to initiate collection and contributed to overall staff comfort with collecting sociodemographic data. The second enabler related to organizational practices that health units adopted to support and encourage sociodemographic data collection. Some health units really prioritized this collection, where senior management's outright support of the work and efforts to socialize SDD collection were apparent and contributed to staff buy-in. Training that highlighted the purpose and value of SDD collection was very helpful. And in addition, some used early adopters or champions to help colleagues with this onboarding and to build buy-in. Many health units developed their own training and other resources, such as scripts translated into multiple languages. Some health units had momentum and practices from having begun collection using a locally built system before the ministry added the fields to CCM and COVAX databases. Locally built systems were user-friendly, enabled quick, easy collection, and included a more comprehensive suite of SDD, and this was seen as enabling in the early days. Some public health units also mentioned the use of virtual assistants to increase completion, particularly during surge periods when increased numbers of people diagnosed and needing follow-up. Another enabler was trust, safety, and care during staff-client interactions. During client interactions, explaining why we were collecting contributed to trust building and client comfort to provide this information. Where community members or ambassadors were involved, they were seen as helpful in explaining the rationale behind SDD collection and contributed to client perceptions of the environment as safe and trustworthy. And this would have been particularly the case for vaccination clinics. Finally, it was clear that learning from the community and other jurisdictions supported SDD collection. Early evidence of the pandemic's inequitable impact from other places, including data from the United States, as well as early insights from communities about the impact that COVID-19 was having on particular groups here in Ontario, highlighted the importance of this work and enabled public health units to prioritize and collect sociodemographic data. Moving on to barriers, 4 sub-themes emerged here as well. The first was related to provincial data systems. Functionality of the databases, particularly the one for COVID-19 case management, were not seen as user-friendly. It was burdensome to locate where the SDD fields were and difficult to input responses. The fact that there was no option to capture Indigenous identity did not resonate and/or was offensive to clients who wanted to identify as First Nations, Inuit, and/or Métis. Not to mention other equity-denied groups such as immigrants and newcomers who are missing from the database, and there was not the capacity to collect that important information. Under organizational and logistical practices, SDD collection was not uniformly prioritized across all levels of management within health units. So while a senior manager might have been very supportive, mid-level managers might not have given it the same emphasis. Also, lack of ongoing training, especially for newly hired staff, as demanding workload could make this ongoing support difficult. Operationally, sociodemographic data collection was more burdensome during surge periods, which led public health units to prioritize collecting other important information over SDD. And finally, public health units reported not being able to engage their communities early on, which hindered their comfort collecting. The necessary community engagement did not happen or was not prioritized. And so they missed this opportunity to reach that level of comfort and agreement with local communities. There were challenges during staff-client interactions, and these included, in some settings, particularly the larger vaccination clinics, they lacked privacy and were sometimes noisy, and therefore they were not optimal conditions for people to share what can feel like personal information. There were time pressures. Participants expressed that they did not always have time to build the rapport they would have liked with clients. Explaining the purpose and utility of SDD could take time, particularly during surge periods. Having this time, carving out that time to create that safe space was difficult. There was discomfort for staff, volunteers, or others helping out in the clinic, particularly if they hadn't received the training to be able to explain SDD collection to clients and explain why we were collecting and the importance. Some additional staff perceptions included some staff expressed their own discomfort or that they would be uncomfortable if they were asked for this information. And this signified a general lack of understanding of the value and rationale for collecting sociodemographic data. While not the focus of the study, the importance of using sociodemographic data did come up, and with that, some barriers to being able to use the data were identified. Under the theme of provincial direction, particularly with vaccination data, there were restrictions on public health units' ability to report on data externally. The province mandated that health units used for internal purposes only and not share externally, and this limited their ability to use the data. From an organizational perspective, participants mentioned the lack of resources, human and otherwise, as well as a lack of guiding frameworks to analyze and report on sociodemographic data. And there were concerns about data quality. Quite simply, very low completion rates and sample size affected data reliability, which limited its usability. And this is a summary slide with the overall themes, the 3 overall themes, and the sub-themes that we just reviewed. I'm going to pass it back now to Manali, who will share some reflections and implications from these findings. Thank you.
Thanks so much, Aideen. So this excerpt from the Ontario Public Health Standards for Health Equity is a reminder of our mandate to identify disparities for the purpose of tailoring programs and services as we did through the pandemic. So whether our access is through linked data or primary data collection, the Ontario standards articulate that sociodemographic data are needed to understand a range of health outcomes and behaviors. As a team, when we were reflecting on our findings, we saw that transformational change was prompted by a burning platform and leadership. So during COVID, the pandemic, we had a unified objective. We had community voice and demand that created an opportunity in the burning platform. And there was will to mobilize provincial infrastructure. So at this point, transformational change is still required, but we are steps closer. We did hear from our results that data collection and data quality have always been a challenge. So it's often in competition to providing immediate direct service. So the ability to make significant changes is difficult at a frontline level without the support of infrastructure and clear, centralized, standardized expectations. Having said this, there have been several equity and pandemic lessons learned documents emerging at the federal and provincial levels that have articulated the need for sociodemographic data with commitments to provide the support and infrastructure needed, such as the Ontario Health Data Council report, Pan-Canadian Health Data Strategy. And this really relates to our next reflection around sustainability. As a research team, we reflected on the need to normalize collection of sociodemographic data among public health unit staff, among our community and clients. When we concern over data quality and use, as Aideen mentioned. And when we don't use, there is not the responsibility to, it is not responsible to collect. So we create some of our self-perpetuating challenges. So however, how in the hesitation of wanting to avoid harms and stigma, we may be diverting attention from identifying disparities. So we do need to normalize the practice. And we know through our study that there is willingness among PHUs to be part of this work moving forward. Based on the findings of our research, there were recommendations for the improvement and scale up of sociodemographic data collection beyond COVID-19 to other public health programs and services. The first set of recommendations is at the provincial and federal level. And based on our findings, we heard clearly about the role for centralized leadership. Our standards and guidance are provincial, our data systems are provincial, and it is recommended that provincial health system partners are able to ground sociodemographic data collection and use by specifically referencing additional details in guidance documents for health units, such as the Ontario Public Health Equity Standard. And this would come with establishing clear mandates for PHUs to collect and use sociodemographic data, including having clear targets and measurable outcomes. With that should come a central and sustained program of support, including standardized training for sociodemographic data collection, a framework for analysis and use, and as well as structured opportunities for knowledge exchange across public health units, such as a community of practice. A central program also includes data systems that have comprehensive and a standard suite of sociodemographic data with easy to navigate fields for data entry. This includes the variables beyond those included during the pandemic. And where possible, there may be opportunities to centralize collection efforts or explore data linkages across the health system to minimize duplication of collection, ensuring that it still continues to be community and client-centered. And none of this is possible without ensuring community engagement to develop and respectfully apply data governance frameworks, such as EGAP and OCAP in the collection, analysis, and use of sociodemographic data. As provincial levers for sociodemographic data collection are used and explored, for public health units, we had a set of recommendations at the organizational level for health units wishing to sustain the work. We need to be able to prioritize sociodemographic data collection and use by enshrining it in our organizational strategies and creating accountability mechanisms like targets and indicators to monitor the work. Similar to the previous slide, engagement with community is needed early in designing and implementing collection. And dedicated resources need to be in place, specifically people and time, to support sociodemographic data collection, analysis, and use within the organization. Comprehensive staff training is key. So recognizing that when staff understand and can share the value of sociodemographic data and have comfort with asking questions, it will foster an environment of trust on the part of the client to provide the information. Staff also need ongoing support through the implementation process by offering a variety of tools adapted to the context, including flexible options for data collection. And as we heard from knowledge users, using data to tailor interventions to the specific circumstances, contexts, and needs of community serve is the ultimate purpose. So we had shared our results with our knowledge user groups. And what we've heard across our several meetings is the assertion that sociodemographic data collection is not a new ask and that we need to acknowledge a history of inaction. We also heard that while our study was focused on collection and completion, that we recognize the end goal is the use of information to reduce disparities. There is a recognition of the risk of stigma that needs attention, but also recognizing that frameworks, as I mentioned, ECAP and OCAP as examples, are there to support us. And as mentioned as well, our community groups emphasize collection of variables beyond those collected during the pandemic to not inadvertently ignore other inequities, such as collection of data around immigration, Indigenous identity, sexual orientation, and other variables. We were also reminded that the context was in an emergency, so findings of facilitators and barriers may be experienced differently outside of the pandemic. However, there was interest from both community organizations and system partners about how we create sustainability and continue the conversation at provincial tables that are focused on health equity. And I'll share a few of our immediate next steps. So for our immediate next steps, over the next several weeks, we will be sharing our LDCP deliverables further, and the full report will be available on the PHO website. For health units, this includes a drafted resource guide where we will be welcoming feedback. And then for our longer next steps, we will be meeting with members of our knowledge user groups to explore ways to move forward on our recommendations through some of the existing health equity oriented tables. And that might assist with some of the recommendations and pushing those forward. This is our last slide before we open it up to questions. And we share our gratitude with all of the health units. So we had 100% of health units responding to the survey and to the clients as well who put trust in us to collect the sociodemographic information. So with gratitude to them. We also sincerely thank all of our knowledge user groups for their insights. And we also thank all the other members of our project team and those who supported the project and presentation. And with thanks to Public Health Ontario's LDCP initiative, whose grant funding allowed us to undertake this work. So I will pass it back to Dr. Morrison for the Q&A period, and we can hopefully explore some questions.
Thank you, Manali and Aideen. Wonderful, interesting presentation and topic. And as we transition to the Q&A segment, please remember to keep entering your questions into the Q&A pod if you haven't already done so, and your participation is greatly appreciated. It is now my pleasure to introduce Dr. Andrew Pinto to the Q&A panel. Dr. Pinto is the founder and director of the Upstream Lab, a research team focused on tackling social determinants of health, population health management, and using data science to enable proactive care. He holds the Canadian Institutes of Health Research Applied Public Health Chair in Upstream Prevention. He is a public health and preventive medicine specialist and a family physician at St. Michael's Hospital in Toronto and an associate professor at the University of Toronto. Thank you for joining us, Dr. Pinto. So I have the pleasure of moderating this Q&A session right now, and thank you very much for the questions that have already come in. I will point to one here, which is, did any of the PHUs that were more successful in collecting data apply it to their programs? And I suspect it means other programs here. And if so, how?
I'm happy to start with a response, and thank you so much for the question. Specifically in our study, so because of the focus group design, we didn't have a way of explicitly measuring this. So some of the impressions, though, that were left were in terms of higher collection rates when data were being monitored and used in real time. So for example, there was public reporting and active monitoring that facilitated higher responses. But we did hear in our focus groups that health units used a range of strategies and tools to help increase completeness. Some that included following up after an interaction, as an example.
Maybe I can add to that too. I think the question too also maybe was seeking how did public health units use the data that they collected to inform their response around COVID around and potentially other programs too. There's some great examples in Ontario where we saw this. We saw this within Toronto Public Health's response, where they were sharing the information on an ongoing basis on an interactive dashboard that allowed the media, allowed advocacy groups, allowed other partners to quickly kind of present disparities in COVID cases and then use it for their own purposes. And it did create a foundation for many groups to advocate to the City of Toronto around funding for community ambassadors to specifically help with like the COVID vaccine effort. And that resources were very linked to what the data was showing. And I think it was a really interesting and rather unique example where we went with a single public health emergency from not having data to communities calling for the data, as was pointed out, to collecting it, to then informing action, and then actually seeing a reduction in disparities. And that kind of last part is something we often lack in Canada, where we're in a relatively short period of time actually shrinking inequities and being able to see it in the data that's collected. And there were of course many other examples as well.
Wonderful, thank you for those insights. I'm going to combine two questions here in that what PHUs may have in place to enhance the collection, STD collection within CCM and COVAX, and specifically if a comprehensive standardized list of potential STD questions has been developed such that health units could consider using these for their own data collection.
I don't mind chiming in. Thanks. I may have missed the second part of the question, but the first part I believe was about how did health units increase collection and completion. I mean, I can talk just a little bit about, well, some of the stuff came through the qualitative response as well. So certainly where public health units had that local leadership, and leadership was engaged and prioritized the collection, that was helpful. Locally crafted tools to support. So, I know in Ottawa, we created posters and pamphlets to actually provide to clients when they were entering into vaccination clinics, for example, which could just start the conversation before the client actually reached the service provider or the person that was going to, ask for this information. To just even start getting the person thinking about it and answering some of those questions. The other thing that was really helpful is, and it came through the research as well, was just finding those champions within teams, like finding those people who are engaged and recognize the importance, and they're leading even within their own teams, and having peer-to-peer training, for example. So getting, champions to actually address their peers and build that support and encouragement within the team was helpful. So those are some strategies. What was the second part of the question?
Yeah, it was around is there a standardized set, and I know Manali in remarks you commented on that. Maybe I could just add that the area of having a standard set of social determinants or sociodemographic questions has been something that we've been working on for over a decade now at the Upstream Lab, particularly for the healthcare service delivery side. And it's built off of work done by many others. And we're just part of a very big community of people who have thought about this. How do we standardize these questions? there is now a growing kind of standard approach to collecting this, which is great. We've tested extensively kind of a tool that's called the Spark tool, which is now being used by others. There's also colleagues at the Canadian Institutes for Health Information, which have done a lot of good work trying to corral people into a national standard. And then Manali mentioned Ontario Health also is moving ahead with a lot of consultation around a standardized way of collecting this. So I see there being a standard set of question, that will be useful and usable and allow for comparison across jurisdictions. And while I have the mic, I'll just also mention that really the Upstream Lab team that was involved with this did a phenomenal job. They included Shagun Ogundele, Mena Komeha, and Joseph O'Rourke. And it's just been a real privilege working with colleagues at Peel and Ottawa on this, along with everyone. But really, this reflects a lot of their experience on how do we collect and use this, and how do we train staff in more the healthcare service delivery side of things.
Great. And I may take moderator's prerogative here and with a hot pursuit of another question, which is if public health organizations across Canada are supporting standard STD indicator, so slightly different from question, but supporting a standard STD indicator list to improve comparability across Canada.
Manala, do you want to speak to him?
Yeah, I actually don't have a good answer to that one. I don't know if one exists in other provinces, and so I'm looking around to people if they are aware of a standard list of indicators. I know in other jurisdictions, having health equity measures and metrics have been discussed, but I can't speak to whether there's something at this point for health units.
I don't think as yet there is something, but like you said, I think the pandemic has really advanced a lot of discussions across jurisdictions in Canada about not only these measures, but are we measuring progress on being able to tackle inequities?
Okay, great. And I know we're on to something because I'm getting a lot of questions now on the benefits and potential disadvantages of this approach. So I'll read two out again and try to combine these, which is considering what the benefit versus a disadvantage of using standardized tools to collect STD data would be, on the one hand, permitting comparison between organizations or jurisdictions, compared to adapting tools to meet the local needs. And a very similar question, echoing that, which is how do we integrate what our local community partners are telling us should we take a centralized direction?
Yeah, that's a really great question and comment. I think, in terms of the standardization, I think we often speak of the minimum data set or the minimum set of data that we would like. But certainly there's local context, to be able to, again, we talked a lot about community engagement and hearing the community voice and what emerges, but certainly being able to integrate that into what we're learning. And then also there's the local application of that information. Andrew mentioned a lot of really great examples through the pandemic of perhaps things that came out of the data, as we mentioned. So for example, the race-based data collection, there's a lot of underlying social determinants that that we didn't collect, but we got a lot of insights from our community members into reasons for disparities, and working with our community partners, we were able to use that information, for example, to design clinics that, for example, are with our BAC communities to be able to increase uptake. So there's a lot of examples of use that is the local context, but certainly the minimum data set is for understanding and really amplifying voices across jurisdictions is really important to have.
Great, thank you. A fairly potentially quick question. In your experience during the project, did you find, generally speaking, that PHU size impacted STD data collection one way or the other?
Yeah, thanks for the question. Admittedly, I'm not sure that we necessarily looked at that and compared size to completion or completion rates. Yeah, so it's a great question. We can take it away and look at it. I have a feeling that it wouldn't be so cut and dry. Like I think that there are larger health units that did very well collecting, some leaders that did well collecting, and then some might think that the smaller units, just because they have less people and less, potentially less people being diagnosed with COVID-19, that the collection might have also been very successful. So I don't think it was necessarily, I don't think that we will see that overall trend. But it's an interesting question.
Maybe just to add to that, it's probably, like you said, unlikely there's a really strong connection because, and if we think of beyond COVID to future public health emergencies or the routine collection of this, there's a small amount of investment in terms of training and ensuring data systems are set up to, allow this. And so that will probably be independent of size, and particularly as resources like training materials and other things like that get circulated and are available, it'll become easier. But the big investment will be on the community engagement side and ensuring units have enough resources to do that really well. And then also action based on what's found. And that's really where a huge amount of energy and resources will be needed. So as over the next few years, we could see the amount of resources and time to actually collect it should diminish, but there will start to be a growing expectation about how are we going to use this, how do we engage, and that's where there'll be needed, new resources and a real need to circulate success stories too, around where did units use this and how did it make a difference, and how did we see it reduce inequities. That will also, compel policymakers to continue to see this as something really, really important.
Great, thank you. I do have a question related to one of the statements made during the presentation, and I'm seeing that there's a similar question in questions coming in as well, which is there's a statement on leaders needing guidance on the appropriate trade-off between data, privacy, and risk of stigma. But there are frameworks to support this. Could you expand on that? And for example, what level of leadership do you think this statement applies most to, or which frameworks come to mind first when we're talking about that balance between data, privacy, and stigma?
Sure, thanks for the question. And I think that was related to one of the points on a slide that I shared. So the comment was an acknowledgement by our knowledge users and community organizations that this work is complex, and what we don't want to do is create stigma. And so again, the central to this was really that, like, the importance of community involvement at all stages. And so there are several community developed frameworks that we listed and touched on. So the EGAP framework from the Black Health Equity Working Group is an example of guidance around collection, analysis, and use of race-based data in a way that really is meant to eliminate anti-Black racism. And so really is framed around the engagement with the communities, community governance, access and protection. OCAP is another one that is an example of that. But in terms of the leadership piece, really I think the accountability is across all leadership in an organizing body to ensure that, as we've talked about, that the infrastructure is really in place to make sure that the collection is appropriate, that we really understand what our data are telling us. Is it complete? Does anything in our results reflect biases? And that we're respectful and intentional about how and to whom that we're releasing information to. So I think any organization that our data has a role in data stewardship.
Great, thank you. I have a question here as well about the type of supports that are or may be coming to PHUs to help implement this, presumably from A to Z. If there's any insight from your part, or perhaps even prioritizing what supports would be most helpful.
Adrian, do you want to take that one at our resource guide?
I mean, let's just, there have been also a couple of questions, just looking at the questions in the Q&A that, sort of ask about expansion, ask about, what's happening now? Are we going back to pre-pandemic status quo? And I just want to be kind of clear that the collection of sociodemographic data really is like, it was introduced during COVID-19, and otherwise, there are bits and pieces that are collected as part of infectious disease reporting and those types of things, but not standardized. So this really is very new work. Like, it's a very new thing for public health units to be undertaking and building capacity for. There's a lot of support needed, a lot of resources needed to, I think, get to what Manali was talking about in terms of getting to a place where there's a standardized way to collect, some standard processes, resources, protocols for collection, that engagement piece, ways to engage community, ways to engage clients, to build that, what Manali was talking about, that normalizing, that this is a normal thing. This is part of public health practice to collect sociodemographic data. But I mean, the question about are we going to go back to status quo? I mean, no, we're in a new era. I think the expectation has been set with community that we are going to collect and use this information for programming, and so what we're posing is that there's a space and an appetite and a need to continue to collect this information as part of public health programs. What does that look like? That's what this conversation is about. I don't know if that answers the question, but just some thoughts.
Yeah, I mean, I think that there's no going back, really. Like, we've collectively had this experience, and it's really more about how do we ensure that it's resourced and done in the best way possible. And we can all start to envision a system where this information is available, and we are not talking about really how we collect it. It's more, what's all the amazing things that are possible, and how are we tracking kind of the impact of interventions, and really understanding that all of the interventions that already happen have a differential impact on different groups. And how can we make sure we're contributing to reducing inequities? And a really powerful kind of thing is, this is an amazing opportunity to engage communities really public health, and letting them know this is what public health is, and these are the great, kind of ideas that we want to hear from you. How do we engage you in this and get communities excited about public health, and do this kind of in peacetime outside of an emergency, and I think there's some amazing examples in Ontario as already of units doing this, and it's just about like lifting that up.
Well, thank you so much. I'm noting the time. Thank you so much to everyone for the wonderful questions. And I do apologize to the small number that we weren't able to get to here. As we conclude today's session, I would like to extend my gratitude to Manal Varia, Aideen Reynolds for their presentation, as well as Dr. Andrew Pinto for his knowledgeable input during the Q&A panel. I'd also like to thank everyone who joined us for today's PHO webinar. You can expect to receive a brief and anonymous survey for today's session. Please try to complete this to help us improve our programming. A reminder to everyone to save the date for the Ontario Public Health Convention, TOFIC, which will be held on March 26th and April 3rd in 2024, and is now accepting abstract submissions for the program. Check out tophc.ca for details. Lastly, to access past presentation and view confirmed upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you and have a wonderful day.